Here we have other people. The second table is pricing versus value for rare disease treatment. I'd like to ask Bruno Abreu. He is from Singles Pharma. Applause, please. I'd like to invite other attendees, Denise Viana, Nelson Mussolini, Rogério Sarabel, also online with Pilar Domingues, Ivera Valente. Thank you very much to all of you.
Em alguns instantes teremos todos
Soon everyone will be with us so we can restart our second roundtable and we will have many contents for you. Prices versus value. It's a very important matter because they show how people have in Brazil. Those are people who everybody one who was invited. Here our last guest. Welcome everyone. Bruno, that's your turn. Good afternoon. It's a pleasure to be here. I'm satisfied to be invited here to discuss these relevant topics like prices versus values, especially when talking about rare diseases. Previous roundtable, we talked a lot about that. So those are diseases with a very low number of patients. So that's very difficult to how to price that the entry pricing level in the market until incorporating and treating the patient journey and everything. It's a pleasure to have you all in this roundtable to discuss that. In this group, just like it happened in the previous Outsable, we have highly qualified people, and each of them they deal with this topic. I would like to welcome Mr. Denis Arviana, professor of the Faculty of the University of Rio de Janeiro, former Secretary of Science, Technology, Strategic Inputs of the Ministry of Health, Nelson Mussolini, my boss, Executive President of Sindus Pharma, over 30 years experience in the pharmaceutical industry, Miss Pilar Domingues, which is in remote, the Mr. Rogério Scarabel, attorney specialized in the health area as president, and Mr. Vera Valente, Executive Director of FENA Saúde. The introductory text of the topic that we're going to deal with is a good summary of the questions afflicting people with rare diseases. Highly specific treatments for rare diseases do not fit in the definition effectiveness. In these cases, it's necessary to have a different look with transparency and respect for the patient population in order to help decision making in the incorporation process. We have here, there are many discussions here. I'll start here. I'll change the logic. I'll start with Dr. Scarabel, who has to take a flight now. So I'll ask him for him to start talking about his experience with the ANS. When you are leading ANS, you're with those orphan drugs. How's incorporations with orphan drugs for people, there is a big challenge how to balance sustainability, technology, and patience. I would like to greet everyone here and also to greet everyone here and my friend Silveira. He's also a rare person. I would like to greet Tony for inviting me. I would like to thank you. This debate, when we were in the agency, I left 25 years, 25 days ago, and I had the opportunity to be there. I also was part of of the direct of the department that incorporate the technology. It's one of the debates that talks about the impact. In 2018, when we got the new regulation 219, we discussed this point and we brought that to the mandatory requirements, the debate and the impact, the economical impact and the budget impact. In that At that time, when we published 465 and 470, we were showing society the impact of this incorporation and the drug impact of each drug, because in the private sector it goes direct to the price. So when 69 technologies were incorporated, we thought about the impact of 1 billion, 1.5 billion, or up to 2.5 billion, and that reflects in the pricing for the health policies. So we're concerned about that. We're we're talking about the not only the pricing but the value in order to bring a benefit and effective for the patient. That's why you needed to have some rationality behind the benefits, an effective benefit for the use for the patient, because this technology is going to be paid by the users. So that's what I was analyzing the incorporation of these technologies that were submitted at the National Supplementary Association that happened on April 1st. And following that, we got the first changes in this new format, in this new process, with this corporation without a window and this discussion, so we could have a better analysis of the rationale, of the effectiveness, of the cost effectiveness by the system. It's an important debate. The agency keeps studying that. There are many challenges. You have PLs, projects, MPs, and a lot and many debates within Congress that we have to care about it. We have to list the agency has to be heard in order to have a suitable outcome without many technologies without incorporating technologies that are not effective and disorganizing the system. We know that we have a resilient system. In this system, we have over 40 million people, and you have to talk about the mutualism, the risk, and the incorporation of new technologies. Within these 50 million lives that are covered are some rare lives. And these lives, through advocacy groups, they are concerned between the difference between the unique. So, for example, we don't have an automatic. So everything that happens within the unique health system should also be incorporated within the ANS with a unique incorporation agency. Talking about that, we're debating that, and for sure, our objective is when I started that in 2018 is to align the guidelines and align those technical matters, manuals, guidelines. Conitec and my agency have the same guidelines, but submitting without having a continuous submission at the same time as the Conitec, what we need to do is to see what are the limits and Conitec limits. For example, Conitecs have some public concerns in 20 days.
I apologize. I keep saying us, because I was there. So, but the agency has some limitations. For example, a consultation shouldn't be in less than 45 days. There are some decisions, the decision makers that need to have time to analyze the request. So if we try to figure out these issues, and in order to analyze and align everything, we try to everything that's been assessed by Polytech, we could only use the economic part of it. And we did like 23 incorporations from CONITAP that had already been assessed. Otherwise, we would be wasting resources, human resources, but also financial resources. So I think it's possible to make this alignment. I don't know if we are mature enough right now. We need to align process, and I think that that would be the best way to deal with it. Something that we still need to mature. It's a discussion that it's bubbling. Everybody's been discussing it, and when you think about the structure, the Brazil's structure, we have the health assessment when the drug comes to the market, and it is anticipating some of discussions that we have further on. But it's important to align all that. When you think about assessments that have some mathematical point of view, you could have like 3 different assessments for every product. So it's not it go against the financial issues, and it can hinder the drug coming to the patient. So I like to say, sorry to interrupt, but for that reason, we've had so many participations and so many openings for the broad social participation lately, because I want to believe that it's the highest patient participation through their institutions, and that was for the health agent, the supplementary health agency. The whole society could submit, I mean, can submit, and they did. They submitted. We had 156 submissions. 3 were elected to be assessed. 30,000 participation in public consultations. You can see how important it is. So the participation, we had a hearing, and I was really happy with what the FDA doctor said, Dr. Daniela, because we have our technical meetings. We had 27 meetings to listen people, and some of them were the patients who were there to talk about their life experience. And if you look, all of our reports, all our dossiers, many decisions were taken with the amount of life gain and the non-progression of the disease. So I think have all that we take that all into account. So excellent. Now, Dr. Denise Arviana, You had a very brilliant time at the ministry. We know your life story. So what can be done in Brazil to make high-cost high-cost drugs more accessible and more systematic? Thank you all. Thank you, Bruno, for your comments. I'd like to thank the opportunity to share this space with people I admire,
Queria também parabenizar o
some
Tony.
friends, and I'd like to congratulate Tony. He inspires all of us with the mission he's embraced. And what we have been discussing here in order to give access to the population for these drugs.
Formulação de uma política pública.
And in formulating health public policies, the policymaker needs to treat equally, unequals unequally. Why I'm saying that? Because when you have rare disease in place, we need a specific policy. Some countries have already done that. And now I want to discuss a specific issue in terms of the decision-making process to incorporate to those high-priced drugs. We know that due to research and development for a very specific niche of patients, we need to have a very strong criteria. So if you look at the tripod of technology health assessment, the first thing is scientific assessment. And there we have a limitation and uncertainty for this group of disease, because we have a small amount of people, clinical trials are small, and there are some uncertainties in how the policymaker can progress in this subject. One thing would be to use different forms of analysis. Real-life data technology has advanced a lot in terms of effectivity studies, real-world studies. So we can do it with a level of information, and we can combine with data that will come at a due time, right? So that's the first issue. And dealing with the uncertainties that permeates the discussion of rare disease and high-cost drugs for this set. So another important topic, and I think we mentioned that in the name of this roundtable.
Parâmetro de custo-efetividade para uma doença prevalente.
We cannot use the same parameter of risk and benefit for rare disease. We need to have different parameters, and some countries are progressing, like defining stratas, so we can look those who are not equal inequally. And I think Bruno comment on that, the impact on budget. And that is one of the come to mind to the manager. So we need to go after different models for incorporating them. Of course, the impact is important, and they need to be well assessed and with a lot of criteria. And how does the world approach that? Sharing models, and the manager in some cases can use like reinsurance. There are other ways to progress, because today this model, and I'm going to talk about SUS, the Brazilian public health system, the payment model from the Ministry of Health, considering its legal model, is not visible, considering the new technologies, especially in Brazil. When you define NCI, NICE is a definition for society, in our legislation, it penalizes the society because it generates inequalities, because those with access, they have a background, the idea that the legal system can create equalities. What's wrong? It was important to bring that to the table, but it must be the exception to make it through the legal system.
Tratar a regulação de uma maneira mais efetiva. E cabe ao gestor, Bruno, cabe ao formulador de política de
To
saúde,
treat the regulations as it should be, depending on the issue. We cannot close our eyes to these realities. If I have a medication that will change the journey, the history of this disease, we need to make it happen, and that's the greatest challenge. And our Congress has been helping us. They've been creating law projects to bring access so that the legislators can take action. I think that's that. Yeah, of course. Judicialization is not good to anyone, definitely, especially in medication for rare disease. We have a very small N for our patients. In a plant, sometimes you have a logistic for a whole country, and judicialization doesn't allow you that. The manager sometimes cannot do it. So what are the main lessons learned that you had from your experience? Because you tried to bring and try to make this experience a part of self-state, and it didn't work. It became just a government thing. Well, my learnings were huge, actually. Public managers, they can do only what they want, only that they allow you, that the law allows you to do. For private managers, you do everything that the law doesn't say you cannot do. So, and that's a big issue in Brazil. As long as we have this bureaucratic model, the control agents that hinder the manager's position, and we have many control agencies to prohibit many things, and that is to allow the managers with responsibility, of course, to progress. So my learnings were that there's a lot of things to do. We have 4.5% of the GDP in public health. Some countries with universal access has at least twice that amount of the GDP. So we did some experiences in risk sharing. We counted with technicians from the Ministry of Health that were very qualified to do that. We managed to put together a research network for assessment, information systems with a huge interface in terms of ethics and research. The patient organizations giving their opinions. We are the specialty doctors. That was huge. That was very good. So when you realize the need for acquisition, legal issues. But now it is a law project. It's still in Congress. So, and that's the time for the executive power to help us. Managers, they need to innovate. If they have the base, if they have the law, they can progress, they can advance, for sure. And we do think about the principle of legality when we go to the Chamber of Drugs, right, that we have here. When we pricify, the pricification process, the pricing process is very old-fashioned, and many decisions are making based on those laws. So it's something that we really need to think about. So we need to reconsider all that. Now I have a question for Dr. Pilar. The main challenge for incorporating new technologies are high cost and the criteria for regulatory agencies. How NICE is treating all that?
Thank you so much for the invitation to be part of this roundtable. I'm really excited to be joining you all from the UK. So the question that you point to me, it's very interesting. So for those of you who do not know NICE, we are the a health technology assessment agency. So basically, we are the equivalent of Conitec in the UK. And we have different programs at NICE to evaluate health technologies for rare conditions. So we have our, let's say, most famous program, that is the Technology Appraisals Program, that evaluates all sorts of medicines, including some for rare diseases. But for those very rare conditions that are very different on how they impact the patient's life, we do have a special program called the Highly Specialized Technologies Programs, particularly because those technologies are also funded differently in the UK and in England. So this Highly Specialized Technologies Program is actually a recognition and an acknowledgement that treatments for rare conditions, very rare conditions, command a premium in the health system because they normally wouldn't be considered cost-effective based on our normal cost-effectiveness threshold or what we would consider a good use of the limited NHS resources. So with that in mind, we created this program because there was a real need to offer an objective, transparent, and systematic way to actually fund these technologies into the system. And actually, there was also a claim from stakeholders that were seeking clarity on how these technologies were incorporated into the system. So that's why we have a special program at NICE that looks specifically at technologies for very rare conditions. But then, as I was saying, we also have our Technology Appraisals Program that looked at at rare diseases as well. Not very rare, but they include other rare diseases. And actually, historically, there has been some claims on the gaps between what is considered rare or very rare. And we currently have done a methods review of our technology appraisals methodology, actually all our methodology for health technology evaluation. And this methods is actually under consultation at the moment by the public. Anybody can access it through our website at NICE. But one of the aspects that has been included, and that's why I wanted to mention it today, is a better recognition that some rare diseases felt missing in this program. So we look at the literature for evidence on what society actually values. And we actually found that society in the UK seems to value more treatments that are targeted to severe conditions. So the more the severe the condition is, the more the society seems to place value for a treatment on it. So we have proposed including severity as an element of value, as a modifier of the decision-making framework in the Technology Appraisal Program. So in that sense, technologies that are targeting severe conditions will be valued more. We look also at other factors, and you may be wondering whether rarity was amongst them, and it was. We look at rarity, but we didn't find evidence that rarity per se will be valued more by the society as a whole. We found that actually was the severity of the condition was actually inherent in most rare conditions and rare diseases. It's what it actually triggered that element of value. And hence we didn't propose a modifier or an element of value for the rarity element itself, but for the severity instead. And actually, we think that by the introduction of this element of value or this modifier in the decision-making framework, it will allow a better reflection of the technology's value to the NHS and also to the patients. But we didn't stop there. We also looked at the sort of evidence that we may find in the case of rare diseases. And it was discussed earlier in the previous roundtable, and I think that in this one as well, the need of using other type of evidence and looking at real-world evidence as well. So we acknowledge that actually generating traditional level of evidence might be particularly difficult in some circumstances, and have proposed that in specific circumstances, we will allow greater flexibility where evidence generation is particularly difficult and is justified. And we mention rare diseases as a case for that. So in that sense, it doesn't mean that we are not looking for robustness or scientific rigor. We still expect the highest level of evidence, but the highest levels of evidence according to the relevant context. So in the case of rare diseases, we have said that if the best level of evidence is available for what it actually can be generated for that condition, we will allow greater flexibility in the decision-making framework to be taken into account when our committees make their decision.
Todos nós sabemos, e o NICE é uma referência para quem milita nesse meio.
We all know that NICE is a reference for those who work in this area, that they work with very specialized technologies. Could you tell us a little bit more about these initiatives?
Sure. I mean, there is currently a changing landscape in the rare diseases world, and you're much more familiar with that than I am. And luckily, fortunately, we are also seeing an increase in rare disease treatments. So one of the things that we have been working on is the need to have criteria that are clear and precise to decide which technologies are actually going to be evaluated through this highly specialized technologies program. And we have currently done a consultation as well on the selection criteria to enter the highly specialized technologies program, with the aim to provide more predictability and clarity to the decision makers and all stakeholders, patient and industry, to actually be able to predict which type of program will be looking or evaluating its technology. And with them to increase transparency and also make the topic selection process much more efficient. So technologies that are selected for the highly specialized technologies program will have to meet 4 criteria. So one of them is, and I mentioned that before, is that the condition should be very rare, and that is defined by 1 in 50,000 in England. And we will say that it's normally that the technology is not indicated for more than 300 people in England that will be eligible for that technology in the license indication. And if the technology has that more than one indication in its portfolio, we said that there will be more than 500 patients eligible across all the indications in the country in England. We also established that the condition should be very rare because, and actually have a significant impact in the sense that it shortens life or has a severe impact on health-related quality of life, impairing the quality of the life of the patient. And also that there shouldn't be any satisfactory treatment available, or if it does, this new technology should be of significant benefit to those affected. So basically, it should be a real step change in how the disease is being managed. So all the 4 criteria should be met in order for that technology to be selected for this highly specialized technologies program. And within this program, the elements of value that are taken into account are also slightly different. So we still looked at the clinical effectiveness in terms of the impact of the technology on the patients and their family members when relevant, or their caregivers, the nature of the condition, of course, the cost to the NHS, and any indirect and non-health benefits that might be associated with the new technology, how that will impact the delivery of the specialized services in the NHS. And last but not least, we still look at value for money and cost effectiveness. However, as I said, normally treatments for very rare conditions will rarely meet our normal threshold for cost effectiveness. So we do have a premium for these technologies, and we accept technologies with an associated incremental cost effectiveness ratio of up to £100,000 per quality adjusted life year gain, with the option to still apply another weight to those health benefits, the more qualities or the more quality adjusted life years the technology brings. So we are actually valuing more the magnitude of benefits. So the more health benefits that the technology brings as compared to whatever is currently done in the NHS, the more it will be rewarded. So for example, technologies associated with more than 30 additional quality adjusted life years compared with whatever treatment or whatever process is being made, established in the NHS for treating that condition, we will apply a weight to those quality gains and be able to recommend that technology that offers at least 30 qualities as compared to established practice in the NHS, up to a threshold of £300,000 per polygain. So it's actually a significant increase as to compare with our usual threshold of cost effectiveness of what we do consider a good use of NHS resources in the NHS for other type of technologies. And as I said, the aim is to actually recognize what matters most, and what will attract the highest premium is that therapeutic or magnitude of benefit of the technology. That's what we really want to promote. That's what we really want to encourage, real innovation, really a step change for patients and the NHS, and hence that's why there is a premium associated with them. Thank you.
Obrigado. A gente sabe que o Mussolini...
Thank you. We know that Mussolini, everybody knows, besides being a president executive, is also a member of CONITEC. The question that we have here is the system sustainability. What are the elements that are critical for this assessment? First of all, I'd like to thank Tony for inviting me. It's an exceptional work that you've been doing, and we have to honor that. And I'd like to talk about the pandemic beforehand. We're missing 600,000 lives, and you have to honor the doctor, nurses, physiotherapists, nutritionists, nurse assistants, ambulance drivers who care those patients, saving lives. We cannot forget this army of professionals had the pharmaceutical resources developed for us. At the beginning of the pandemic, we had a meeting, and one of the directors, it was March last year, I'm sure the pharmaceutical industry will bring solution to these problems. I also wrote an article saying that I believe that regarding the problem that we have here between cost and effectiveness and treatment, cost and treatment, the debate that we face, Dennis has approached this important matter that it's you see that horrible those judicial lawsuits, because that disrupts the budget. A budget's not enough for what you have to do, and you have extra costs with the judicialization that takes advantage of the number of a small number of people. We have to rethink that in our country. The higher courts have to look into that with some more criteria, because that might damage our society as a whole. Another matter that you have to have in mind, last week I was discussing that we cannot have the pharmaceutical assistance as an expense either in the private sector or in the public sector. The pharmaceutical assistant is an investment. If we don't see pharmaceutical assistant as an investment, we will have severe problems in our country in every area. In rare diseases and common disorders as well. You know, like popular drugstore is a typical element when it's effective, reduce your health care costs. When you treat effectively the rare, you reduce costs in the society, and that has to be assessed when you're going to incorporate either the public or private sector of a new technology. The cost behind that has to be seen as an investment, because you're generating the possibility for the caregiver to work and generate income, or the patient to be able to be professionally active and generate also income for the country. Developing co-participation, co-pays, or a co-participation between the public and private sector with the pharmaceutical industry. I like to mention both. It's a decisive factor, and I believe that's going to keep happening. We have to effectively have a system, a participation system, an effective one. Then try to do that, but what was going to be a state policy didn't become a state policy. And in this field, we don't have to talk about a government policy or secretary. So, as it happened before in the past, we need to debate this matter in a clear way. Congress participation is crucial. Those congresswomen who are here are extremely important to have a clear debate with public hearings and participate within Congress of the dissipating, closing this equation, which is not easy anywhere in in the world, especially in a country who says that we have universal health care, that you have that's a right, but we only spend 4.5% of our PNB in healthcare, while other countries with, for example, in the US, they spend 10%. So we see there is something wrong in the way that we address those matters. A clear, transparent debate, seeing healthcare, and the pandemic highlighted that as a solution for a problem solution, but not as a problem, would help us to achieve and solve the equation effectively. And talking about this, what many patients and caregivers are questioning the industry role in this process, how the pharmaceutical industry can help in the budget impact. I've always said that the matter is on the number of patients and the time frame that you have the technology as a unique technology. When your technology is a priority, when you have a small number of patients, you have a production cost that has to be shared among several people. That's so those pricing gets to matter, a complicated matter that have to be managed by state and by the private system. The private system has a solution because they have a easier negotiation and they're able to price that. The public sector has some limit budgetary and they don't know how to bill that to other people. So that's more difficult. The private sector still can share this cost among the users, and the public sector, that's more difficult. So I don't know. So I believe that sharing risk is the part that industry can take. That's a space where we can work. It's not a a large space, but when I define and I present my technology, and I tell that my technology will provide care for 50 for 500 people, I have to be responsible that if there are 501 people, I'll have to pay for it. That's an easier system when you share risk. So some So some procedures can be very difficult in such a big country like ours. So it's hard to follow up efficacy, technology, safety in such large country. So when I use clear targets which are easily measured, I don't see another way out. I don't see another way out for for private public system without a co-responsibility for what the industry is going to deliver, how it's going to deliver, and to whom it's going to deliver. I that it took too long. It took too long for us to discuss. We needed to have a congress with that because there are many elements that may confuse or disrupt the system, but we see that the society is moving forward in depth. Another question for Vera Valente. Can we say that policy, there is a private policy for rare disease in the private sector, specifically for this group of patients? Always a mute microphone. Good afternoon, Bruno, everyone. Here, I would like to salute my panel colleagues. I'm here among friends. They know a lot about this topic. I would like to thank Casa Hunter for the opportunity because he's very important and he is someone who there are many points that can be better understood. It's very good to be in this technical topic with all these people, the best practice in the whole world in incorporation, ensuring access to the best technologies. I would like to highlight that every system, even the most advanced ATS, is the best tool for incorporation decisions. In none of these countries there is an automatic incorporation. Some people are defending that. Here we have been emphasizing against a law that will open this possibility, an automatic one that was vetoed by the president. It doesn't exist anywhere, and you have to respect the regulatory organization, his com- how his technical expertise. This is not something that has to be through law. Is not good for society, not good for the public sector, and not good for the private sector. Our supplementary system treat equally each user. There is not a specific user who specific. We comply with every regulatory, even though there are specific in terms of coverage defined for rare diseases. That doesn't prevent those technologies to be able to used by the users. ANS has incorporated several technologies for these pathologies. The insurance policies cover procedures, treatments for rare diseases when all rare diseases in seed are supported by the operators. They have gene test coverage and medication. Recently, procedures like allogenic transplantation for MPS was incorporated, Paget, multiple sclerosis, MS, hepatocellular, among others. So the number of pathologies has been updated every 2 years, and the last update embraced those procedures and medications for rare diseases. And now, as we mentioned, a modification NES that has become this whole continuous is not every 2 years. And after all this discussion, when it was going to eliminate ATS for some medications in Brazil, the government president, we had an executive order to solve the deadline. You have to keep an assessment, a technology assessment. Used to be long, 2 years is too long. Now this matter has been solved, and with an executive order that has reduced the time frame, making it continuous without eliminating assessment and the society. This process brings the discussions for patients, associations, medical associations, payers, developers in a democratic discussion that we consider very important for having the best choices, the most important one, proving in a way that they can be incorporated. For the patient safety, we cannot stop assessing technology. Facts are the most important, evidence is the most important element for cooperation, and the cooperation has to be rational with transparent process with the civil society participation, measuring the benefit, the incorporation in regards to treatments that are available with evidence, benefit, and KPIs. Of course, for rare disease, is there are some specific challenges because there are some evidence that prove efficacy, safety, and benefit for the technology. It's different with more common diseases, but that's not a problem for Brazil, but also Pilar has mentioned and explained here. Another aspect that you have to talk, we cannot stop it for medication for both rare disease for and also for any disease of the pricing and financing, as it has been discussed before. Cannot ignore the budgetary matters, especially when there is some lack of resources. Health insurance share those costs. They receive those premium payments and they have to manage those premium money because those this money has to pay for an expense. So that's very important that we have to be responsible when incorporating technology because the consequence is going to be shared among all users within the system, and that's the basic pillar of the supplementary health system. Even though there is no deadline, different methodologies for rare diseases, the operators they're not restricting access for treatments and technologies coming from methodologies applied by ANS. Thank you very much. Oh, thank you, Vera. Right now, because we have extended a lot, so I want to get 30 or 40 seconds for each one of you to do some closing remarks. Let's start with Dr. Pilar and then Vera.
Thank you so much. Well, NICE and different stakeholders in Brazil have been collaborating very closely through the last couple of years, particularly with Conitec. And I'm grateful to say that some of the topics that we've been collaborating are some of the topics that have come up today. So we have worked together on how both of our agencies incorporate patients' testimony in the decision-making process. I know that Conitec last year started involving lay members in their committees, which I think that is a great success. And I think that it will improve the decision-making process in Brazil and also will give a voice for those communities as well with rare diseases. Another topic that we have been collaborating on talking about is the managed access agreements. And I know that before we were talking about sharing risks. So we've been sharing how NICE have been able to recommend some technologies thanks to the use of some managed access agreements that allow for the continuous collection of data after a recommendation has been made for incorporation in the NHS for a temporary period. So with the aim to reassess the technology after that data collection period, because there is clinical uncertainty and also cost effectiveness uncertainty. And another aspect that we have been also collaborating is in the topic selection criteria. And I think that Conitech is doing great progress and improvement in how they can improve the horizon scanning and their topic selection process, so it's more transparent and more efficient, both internally for Conitech, but also for stakeholders, that they will be able to see where in the process the technology is. So I'm really excited to see the progress that is being made, and I really look forward to collaborations. And I'm pretty sure that this will bring benefits for the rare disease community and for the overall patients community as a whole in Brazil. So thank you so much for the invitation. It's been a pleasure.
Thank you. Vera, suas considerações finais, por favor.
Vera, your closing remarks, please. Vera? I'd like to thank you for the invitation, and we have an important space to discuss innovations, new technologies. Everybody has to take part in it, based in science, data, payer, private or public. Also, the technology provider have to explore new financing models, not only sharing risk, but there are different models that we could have a better discussion, pricing discussion. This pricing discussion is very limited. Right now, we have a public consultation that will be an opportunity to understand the corporation pricing. Once defined pricing, there is pricing to sell a little bit and to sell a lot. This discussion, when it's compared, this whole society is gaining with that. We want to take care of people, to have access to better technology, to have better quality of life with fair choices, because we're talking about a society, and the technology owner should be part to help either the public or private system to give access to this system. Thank you to this treatment. Thank you very much. Mussolini. First of all, I'd like to thank for the opportunity. This debate is clear, is transparent, and very good, with some different positions. But through those discussions, we find a solution. If you cannot debate different opinions, that'll be a problem. I've been Conitech since the beginning. The development, looking examples abroad, and the development has been big and has brought great gains for the society as a whole. The development that we had at Anvisa was also very clear compared to other world agencies. They are the same level as FDA. We saw in the previous. We feel that Anvisa today is acknowledged as an agency that's concerned with efficacy, and that's very important. And we have to keep chasing that within NNS. Unfortunately, we see how we've been struggling at NES for lack of people, for not meeting deadlines. It takes 3, 4 years to see DS without any justification, and that's a great damage for the society, both for the private and the public sector. And the number of judicialization that was unique within the public system today is being going through the private sector, even in a higher level. If we don't look into that and you have the ANS for effectively, if it is not effective, the health insurance will face the same problems that you have in the public sector. And we suffered so much with that because we, in that way, you don't have any condition to forecast. And forecasting in our sector, in industry, or in the public or in the private sector, in healthcare, it's essential for our sector. Thanks so much, Mussolini. Thank you, Bruno. I would like to thank this opportunity, and I would like to. We have to have a pact after pandemic, especially within the unique health system. We have to we have to waive taxes. We have to discuss that. We have to find money. How to do finance management with the legislation. If we don't improve legislation, we won't be able to use these resources. This process is scarce. We have to qualify we have to redo the emergency rules. We have to, that'll improve that without lawsuits, especially if we can centralize purchase to reduce pricing. Those are important matters that society must discuss. When I talk about medication, we have to also talk about patient care. We have a problem for medium complexity to find specialists, start talking about telemedicine to have better outcomes in healthcare. I I agree completely. Thank you everyone for the clarity, for the kindness, for being so. I'd like to appreciate all the attendance. Thank you very much.